The liver, its functions, diseases, disorders, and laboratory assessments. In this presentation, we will discuss the anatomy, biochemical functions, disease states, and alterations to liver function due to those diseases, how liver function is assessed, and the tests done in the laboratory. The liver is the body's largest internal organ. Its critical functions include metabolism of carbohydrates, lipids, proteins, and bilirubin, detoxification of harmful substances, storage of essential compounds, and secretion of harmful substances. The liver is a unique organ due to its resiliency and its ability to regenerate cells that have been destroyed by short-term injury or disease, or have been removed. However, it is important to note that repeated damage can cause permanent changes, and death will occur within 24 hours if the liver remains non-functional. The liver weighs approximately 1.2 to 1.5 kilograms in a healthy adult. It is located beneath and attached to the diaphragm and is protected by the lower rib cage. It's held in place by ligamentous attachments. The liver is divided into two unequal lobes, and the right lobe is 6 times larger than the left. The liver is extremely vascular and receives blood from both the hepatic artery and the portal vein. The excretory system of the liver begins at the bile canaliculi, which are small spaces between the hepatocytes where excretory products can drain. The bile canaliculi between the hepatocytes form intrahepatic ducts, which join to form the right and left hepatic ducts. The hepatic ducts drain the secretions from the liver. The liver is divided into microscopic units called lobules, which are the functional units of the liver responsible for metabolic and excretory functions. Each is a 6-sided structure with a central vein and portal triads at each corner. Each triad contains a hepatic artery, a portal vein, and a bile duct. There are 2 major cell types in the liver, Kupffer cells and hepatocytes. Kupffer cells are macrophages that line the sinusoids of the liver and act as active phagocytes capable of engulfing bacteria, debris, toxins, and other substances. Hepatocytes make up approximately 80% of liver volume. They are large cells that perform the major functions associated with the liver and are responsible for the regenerative properties of the liver. Here we have a diagram depicting the microscopic anatomy of the liver. The liver performs 4 major biochemical functions: excretion and secretion, metabolism, detoxification, and storage. It is important to remember here that proper liver function is so vital that if the liver becomes non-functional, death will occur within 24 hours due to hypoglycemia. In liver failure, stored glycogen within the liver is unable to be changed to glucose and released into the body. One of the most important functions of the liver is the processing and excretion of endogenous and exogenous substances into the bile or urine, such as the major heme waste product bilirubin. The liver is the only organ that has the capacity to rid the body of heme waste products. The liver is responsible for metabolizing carbohydrates, lipids, and proteins. When carbohydrates are ingested and absorbed, the liver can use the glucose for its own cellular energy requirements, circulate the glucose for use at the peripheral tissue, or store glucose as glycogen within the liver itself or other tissues. It also maintains stable glucose concentrations within the body. Lipids are metabolized in the liver when nutrition is adequate and glucose demands are being met. The liver is responsible for gathering free fatty acids from the diet and the liver itself and breaks them down to form acetyl coenzyme A, which in turn forms triglycerides, phospholipids, or cholesterol. Almost all proteins are synthesized by the liver except the immunoglobulins and adult hemoglobin. One of the most important proteins synthesized by the liver is albumin. It also synthesizes acute phase reactants and coagulation proteins and serves to store a pool of amino acid through protein degradation. The most critical aspect of protein metabolism includes transamination and deamination of amino acids. The liver serves as a gatekeeper between substances absorbed by the GI tract and those released into systemic circulation. There are two mechanisms for detoxification of foreign materials and metabolic products. The liver may either bind the material reversibly so as to inactivate the compound, or it may chemically modify the compound so it can be excreted. The most important mechanism is the drug metabolizing system of the liver, which is responsible for the detoxification of many drugs through oxidation, reduction, hydrolysis, hydroxylation, carboxylation, and demethylation. Now let's take a look at how different disease states alter liver function. Jaundice is one of the oldest known pathological conditions reported. It is used to describe the yellow discoloration of the skin, eyes, and mucous membranes, most often resulting from the retention of bilirubin. Jaundice is most commonly classified based on the site of the disorder: prehepatic, hepatic, and posthepatic. Prehepatic jaundice occurs when the problem causing the jaundice occurs prior to liver metabolism. It is most commonly caused by an increased amount of bilirubin being presented to the liver, such as seen in acute or chronic hemolytic anemias. This type of jaundice is most often referred to as unconjugated hyperbilirubinemia because the increased bilirubin is the unconjugated fraction. Hepatic jaundice occurs when the primary problem causing the jaundice is an intrinsic liver disease or defect. This can be due to disorders of bilirubin metabolism and transport defects, or due to diseases resulting in hepatocellular injury or destruction. Posthepatic jaundice results from biliary obstructive disease, usually from physical obstructions such as gallstones or tumors that prevent the flow of conjugated bilirubin into the bile canaliculi. This chart shows the changes in serum concentrations of bilirubin in those with jaundice. Notice total bilirubin is increased in all forms, but conjugated bilirubin is decreased in Crigler-Najjar syndrome due to a complete absence or severe deficiency of the enzyme responsible for bilirubin conjugation. Now let's look at cirrhosis of the liver. Cirrhosis is a clinical condition in which scar tissue replaces normal, healthy liver tissue and blocks the flow of blood through the organ and prevents the liver from functioning properly. Cirrhosis rarely causes signs and symptoms in its early stages, but as liver function deteriorates, the signs and symptoms appear, including fatigue, nausea, unintended weight loss, jaundice, bleeding from the gastrointestinal tract, intense itching and swelling in the legs and abdomen. Although some patients with cirrhosis may have prolonged survival, they generally have a poor prognosis. In the United States, the most common cause of cirrhosis is chronic alcoholism. Other causes of cirrhosis include chronic hepatitis B, C, and D virus infection, autoimmune hepatitis, inherited disorders, non-alcoholic steatohepatitis, blocked bile ducts, drugs, toxins, and infections. Here we have a comparison between a healthy, normal liver and a cirrhotic liver. Cancers of the liver are classified as primary or metastatic. Primary liver cancer is cancer that begins in the liver cells, while metastatic cancer occurs when tumors from other parts of the body spread or metastasize to the liver. Metastatic liver cancer is much more common than primary liver cancer. Tumors of the liver may also be classified as benign or malignant. The common benign tumors of the liver include hepatocellular adenoma, a condition occurring almost exclusively in females of childbearing age, and hematogiomas, masses of blood vessels with no known etiology. Malignant tumors of the liver include hepatocellular carcinoma and bile duct carcinoma, as well as hepatoblastoma, which is an uncommon hepatic malignancy of children. Whether primary or metastatic, any malignant tumor in the liver is a serious finding and carries a poor prognosis, with survival times measured in months. In this picture, we can see a liver with 3 separate tumors. Reye syndrome is a term used to describe a group of disorders caused by infectious, metabolic, toxic, or drug-induced disease found almost exclusively in children. It is often preceded by a viral syndrome such as varicella, gastroenteritis, or an upper respiratory tract infection such as influenza. Studies have demonstrated a strong correlation between the ingestion of aspirin during a viral syndrome and the subsequent development of Reye syndrome. Reye syndrome is an acute illness characterized by non-inflammatory encephalopathy and fatty degeneration of the liver, with a clinical presentation of profuse vomiting accompanied by varying degrees of neurologic impairment. Without treatment, rapid clinical deterioration leading to death may occur. Rule of thumb: don't give aspirin to a child with the flu or chickenpox. Drug-induced liver disease is a major problem in the United States, accounting for 1/3 to 1/2 of all the reported cases of acute liver failure. Many drugs are known to cause liver damage, ranging from very mild transient forms to fulminant liver failure. Drugs can cause liver injury by a variety of mechanisms, but the most common mechanism of toxicity is via an immune-mediated injury to the hepatocytes and results in hepatic and/or cholestatic disease. Of all the drugs associated with hepatic toxicity, the most important is ethanol. In very small amounts, ethanol causes very mild, transient, and unnoticed injury to the liver. However, heavier and prolonged consumption can result in a spectrum of liver abnormalities that may range from alcoholic fatty liver with inflammation to scar tissue formation, as in hepatic fibrosis. Alcohol-induced liver injury may be categorized into 3 stages: alcoholic fatty liver, alcoholic hepatitis, and alcoholic cirrhosis. Alcoholic fatty liver represents the mildest category, where very few changes in liver function are measurable. This stage is characterized by slight elevations in AST, ALT, and GGT. Alcoholic hepatitis presents with common signs and symptoms including fever, ascites, proximal muscle loss, and far more laboratory evidence of liver damage, such as moderately elevated AST, ALT, GGT, and ALP, and elevations in total bilirubin greater than 5 milligrams per deciliter. The last and most severe stage is alcoholic cirrhosis. The prognosis associated with alcoholic cirrhosis is dependent on the nature and severity of the associated conditions, such as a gastrointestinal bleeding or ascites. Laboratory abnormalities include increased liver function tests, AST, ALT, GGT, ALP, and total bilirubin, decreased albumin, and a prolonged prothrombin time. A liver biopsy is the only method by which a definitive diagnosis may be made. This concludes part 1 of this presentation. Please stay tuned for an assessment of liver function tests, and the hepatitis.